Good morning, everyone. I'm Michael McGinnis from the National Academy of Medicine, Executive Officer at the NAM, and it's my great pleasure to join with my colleague Karen Howard from the USGAO to welcome you to this conversation on artificial intelligence and medical diagnosis. This is a wonderful partnership that we've had with GAO now for several sessions on the issue of AI and health. In many ways, even though we're excited and dazzled by the already contributions of artificial intelligence, we're really a little bit like people were back in the 19th century when the first mechanical approaches to transporting people and things began to be developed. With only the dimmest vision of what the possibilities might be in the long term. But it's very clear that society as a whole and medicine in particular is going to be substantially transformed and is not going to look very much like it does now. It's very likely to be a much more democratic in many ways process with participation of each of us in as yet unimagined ways. So we're going to get a glimpse of how things are beginning to develop as a result of the work of GAO on technology assessment, and all of you have a copy of that, and it contains the NAM discussion paper on the issue titled Meeting the Moment, Addressing Barriers and Facilitating Clinical Adoption of Artificial Intelligence and Medical Diagnosis. I want to underscore at the outset the wonderful contributions of our GAO partners and our NAM staff in this respect. You have, and we'll hear from both Karen Howard and Matthew Hunt, in the course of the conversation from GAO. From the NAM perspective, our orchestra leader over here is now Asia Williams. Thank you, Asia, and Noor Ahmed, before she left for Hopkins, has been our spearhead, but we've also had important contributions from a number of folks on staff, including not only Asia and Noor, but Emma Yakutis, Annie Murph, Elaine Fontaine, and thanks to each of you really up front for the great contributions in that respect. If I can just say a couple of things about the NAM and then turn it over to Karen. The National Academy of Medicine, as many of you know, is an independent organization operating under the charter passed by Congress in 1863 for the National Academy of Sciences. There are now three of us: National Academy of Sciences, National Academy of Engineering, and National Academy of Medicine. And our mission at NAM is to improve health for all by advancing science, improving health equity, providing independent, authoritative, and trusted advice nationally and globally. In effect, our basic responsibility is to do the best we can to rally the evidence to indicate what at the moment is established truth. Of course, in an area like artificial intelligence, and indeed in many realms of science, the pace of change is moving so rapidly, it's a little bit like taking a snapshot in a horse race to understand exactly what the state of play is. But the processes that we use are tried and true, time tested, and so we take very seriously our mandate to provide the best counsel to the American people. And it's especially nice to be partnered with another organization that has that same value and spirit, the U.S. General Accounting Office. Next slide, please. The component of the National Academy of Medicine that has been stewarding the work here is the NAM Leadership Consortium, which is a number of about 4 dozen stakeholder leaders in private, public, and independent organizations from health sectors that collaborate together under the auspices of the National Academy of Medicine. So we have a number of organizations that are directly involved in building the field in this arena as part of the Leadership Consortium. Their common interests are essentially advancing effectiveness, efficiency, equity, and continuous learning in health, medical care, and biomedical science. Next slide, please. The collaborative or the consortium works through 4 collaboratives, which together represent the elements of a continuous learning health system, which is one in which science, informatics, incentives, and culture are aligned for progress. And so we have collaboratives in each of these areas, including one on informatics, our Digital Health Action Collaborative, which seeks to position the digital infrastructure and data as a core utility of our health system operation. And it is that collaborative that has served as the steward of our contribution to the work today. Next slide, please. The agenda that we have lined up with our GAO colleagues is a very interesting one, in which will guide us into this vision of the future. I'm going to turn in about 30 seconds to Karen to offer a welcome from the GAO perspective, and then she'll move us directly into an overview of the GAO report and the NAM discussion paper. Karen will review the GAO report, and Stephen Lin, one of the authors of the discussion paper from Stanford University, will give an overview of the NAM paper. And then we'll have a panel discussion that will be moderated by Matthew Hunter from GAO, including a number of authorities who are prominent, informed, and knowledgeable and inspirational leaders for the field. Connie Lehman, Barbara Evans, Adewale Adamson, and Dahlia Powers. And then Matthew will lead us in a discussion period. I'll make a couple of comments at the end, and we'll have, I know, a very rich set of discussions. So welcome again. Thank you for joining us, and special thanks to Karen for our partnership.
Thank you, Michael. It's a pleasure to join you again for the third in the series. Just very briefly, I'll mention that I'm Karen Howard. I'm a director at GAO. Specifically, I'm in the Science, Technology Assessment, and Analytics team. And this is, as Michael mentioned, the third in a series of reports that we've done on AI in healthcare. The first 2 were AI in drug development and AI in medical services. This third one concludes the series with AI and medical diagnostics. And it's truly been a pleasure, Michael, to partner with you and your staff on these reports. Thank you for all that you and your colleagues have contributed. I think we do have one housekeeping slide before I dive into the details. Okay, so those of you who are listening in on the webinar, if you would like to join in, there are 2 ways that you can participate in the conversation. The first is to use the chat box. You'll see the instructions for that on the left. And the key thing to note here is that you may see a pull-down menu that allows you to direct any chat questions you might have to either just the hosts and the panelists who are speaking today, or to all attendees of the webinar. So please make sure that you're making the selection to direct your comment to whoever you'd like it to go to. On the right-hand side, it gives instructions for joining the Q&A. You can type any questions you have as the presentation goes along into that Q&A window. Many of them might be answered in writing during the webinar, so please keep an eye over there if you've put a question in or if you're interested in the conversation. Some of them will be selected by Matt Hunter, our moderator for the Q&A session that will come later, and those will be answered live by the panelists. Okay, thank you. Next slide. Next slide, please. So I'm going to talk about our report, the third report on AI in healthcare. I'm going to focus on the GAO portion of that report. And as Michael mentioned, Stephen Lin will be giving an overview of the NAM portion of that report. Let me describe first who GAO is for those of you who might not be familiar with us. We are a legislative branch agency that exists to support Congress. We've been in existence a little bit over 100 years. Last year was our 100th anniversary. And we have a number of different mission teams within GAO that focus on different aspects of the federal enterprise: defense, healthcare, international affairs, trade, everything you can think of that the federal government does. GAO has a team that addresses those topics. My team, the Science, Technology Assessment and Analytics team, as you might guess from the name, focuses on science and technology, how those advancements are occurring, how they're impacting our nation, and things Congress might need or want to be aware of as they think about overseeing and helping to guide those in a policy-directed way. Next slide, please. We are independent and nonpartisan, and that's important to note. Even though we're within the legislative branch, we don't swing with the political winds, so to speak. We provide an objective, fact-based, nonpartisan voice within the legislative branch. Next slide, please. My team in particular does a set of products called technology assessments. And these are really a deep dive into the technologies that either currently exist or that are in the development pipeline that might influence a particular sector of society, or sometimes more than one sector. Sometimes they cut across a lot of areas of the federal government and of the nation. In those products, we're trying to provide foresight about where this technology or these sets of technologies could go, what are some potential benefits of those technologies, and what might be some of the challenges that you could encounter as those technologies are developed and deployed, or some of the challenges that might hinder the development and deployment of those technologies for one reason or another. And then, because our primary client is Congress, we present policy options that policymakers such as Congress and others could consider to help enhance the benefits and mitigate potential challenges of those technologies. For this particular report, the AI and Medical Diagnostics report, and in fact all three of the series, this work was originally requested by two committees in Congress: the House Committee on Energy and Commerce and the Senate Committee on Health, Education, Labor, and Pensions, or Senate HELP, we commonly call it. Those two committees requested this body of work, and we've completed all three of these reports to respond to them. And again, as I mentioned earlier, we're very grateful to have been able to partner with the National Academy of Medicine. They have added very valuable insights to each of those reports. Next slide, please. So this particular technology assessment, let me clarify the scope. Obviously, medical diagnostics is an extremely broad field. We could not cover everything in that field, or we would have a 1,000-page report that nobody in Congress would have time to read. So we tried to scope this around some key diseases in particular and some key diagnostic areas. You'll see on the left there, we focused on certain cancers, diabetic retinopathy, Alzheimer's disease, heart disease, and COVID-19, given the issues of the day. We looked at both currently available technologies and emerging technologies in those areas that use machine learning to try to enhance or provide support for clinicians as they make diagnoses of these conditions. And again, as we always do, we looked at challenges affecting these technologies and policy options to help address them. Next slide, please. Just a quick look at our methodology. We did conduct a very thorough literature review. In fact, we did two literature reviews, one on the technologies themselves and the status of development, particularly of emerging technologies, but also use, clinical trial reports, things along those lines. And we also did a literature review looking at policy. What are some areas that perhaps Congress or other policymakers, state and local governments, and nonprofit organizations such as patient advocacy groups might have proposed along the way for these technologies. We held an expert meeting that was done in full partnership with the National Academy of Medicine. It was a 3-day virtual meeting given the pandemic, and we drew together 16 experts. And these included clinicians, health system representatives, for example, people responsible for implementing AI across a large medical system, researchers, technology developers, regulators, such as representatives from the FDA, ethicists, people to help us understand the legal aspects, and so on. And we conducted a number of interviews in addition to that expert meeting. We conducted interviews with 5 federal agencies who are doing relevant work in this space, 7 technology developers, professional organizations, and prominent academic researchers in the field. So that just gives you a sense of where our information came from. Next slide, please. Some of the technologies we identified and the ways that they work are listed here. Again, the report is more extensive. You should check it out if you're interested in more details. But for cancer, we identified some technologies that analyze data predominantly from images. And those might be MRI, CT, pathology slide microscopy, and X-rays, for example. Diabetic retinopathy, again, these are tools that interpret retinal images. Alzheimer's disease, typically tools that analyze MRI images, looking for changes in the structure of the brain that might be indicators for Alzheimer's disease. Heart disease, we again looked at images, tools that examine radiological images for things like pulmonary embolism, but also wearables that might track conditions like AFib. And for COVID-19, we looked at non-image technologies in this case, but technologies that might help screen asymptomatic patients based on their pulse characteristics or measuring their antibodies using very small amounts of blood. Next slide, please. We did identify, in conjunction with our experts and others we spoke with, several potential benefits of machine learning in medical diagnostics. Specifically, we found that early detection is one that many experts mentioned because the tools, the machine learning tools, can be trained to spot inconsistencies in an image perhaps earlier than a human radiologist reading that image might be able to detect them with the human eye. So early detection is one potential benefit of these technologies. In addition, experts also mentioned that in some cases, such as for diabetic retinopathy, these tools might allow non-specialists to really quickly screen patients, flag those that seem to potentially be at risk, and refer them on to a specialist, which might allow a quicker path into the specialist queue so that they could get a more accurate specialist diagnosis earlier. These tools might also offer advantages in consistency because it is not subject to, for example, clinician to clinician variability or early day, late day variability. We all know as humans that we're sharper at some times of day than others. The machine doesn't suffer from that limitation. And so you might get more consistency in the diagnosis as another potential benefit. And third, these technologies might increase access. For example, in underserved areas where patients might not have access to highly trained specialists just because they are much more rare in those settings. It might also allow reaching in-home or smaller clinical settings. And in some cases, these tools might allow automation of straightforward tasks to reduce provider workload and allow them to focus on the things that truly require their advanced skill set. Next slide, please. We did, however, identify some challenges and potential policy options to help address those. This is not an exhaustive list of what we found. You can look at the report for more, but just a couple to give examples. The first challenge we found is that there is limited data on the real-world performance of many of these tools. And there are a couple of reasons that experts told us that might be the case. Providers might be hesitant to adopt technologies if they don't have evidence of the real-world effectiveness. But testing these in a variety of settings across a variety of patient demographics is time-consuming and it's expensive. So often a technology developer doesn't take those steps to show the applicability across a wide range of conditions where the tool might be used. And so some policy options we came up with there. Policymakers could create incentives, guidance, or policies to either encourage or require the evaluation of machine learning diagnostic technologies across this range of conditions and across the range of demographics. Please note that we worded this as a could. These are, when we present policy options in our reports, we're presenting a menu of things Congress and other policymakers could consider, but we're not making recommendations of things they should do. We're just showing them some of the things that stakeholders, experts, and others told us might be useful. Some advantages of this policy option: it could potentially help identify biases. If we did more thorough testing across a range of conditions, a range of patient demographics, it might be easier to identify ways that the tools might be unintentionally biased or limitations they might have, and it might allow for opportunities to improve the tools. It could also lead to increased adoption by medical facilities and by providers by enhancing trust that the tool is going to be helpful and is going to give reliable diagnostic results and support to the clinician. However, one consideration is that, as I mentioned, this can be very costly and time intensive to create these policies to encourage or require the testing that would be needed, which could, from the patient side, delay the movement of these technologies into the marketplace. So that's always a factor. We, of course, want to enhance patient access and clinician access to the best technologies, but we also want those to be evidence-based. So there's a trade-off there for policymakers to consider. Next slide, please. Another challenge we found is that these tools, it's not always clear whether they meet medical needs. For example, experts told us that it's not clear that a tool might increase clinical productivity. The tools may not integrate into existing healthcare systems and clinical workflows. They told us that quite often technology developers are developing these tools without sufficient input from clinicians and those who will actually need to use them in the real world, and therefore they're not fully understanding how it needs to be integrated into the daily workflow of a provider in order to be a helpful and useful tool. And providers also want to understand the clinical evidence for any recommendations the tools might be giving. And as we all know from looking at AI tools, that's not always easy to discern. The tool learns from a wide range of data, finds the patterns on its own, and determines how to apply those patterns to make recommendations or predictions. It's not always clear how the tool is coming to that decision, and that can make it difficult for providers to trust the tool. So a policy option that could be helpful here, providers could promote collaboration among developers, policymakers could promote collaboration among developers, providers, and regulators in the development and adoption of these tools. This could help ensure better integration into clinical needs and medical workflows. It could also improve our access to, the creation of and access to machine learning ready data. So if providers and health systems understand how critical data are to the development of these technologies and how important it is that those data be usable for machine learning training purposes, then perhaps we can encourage or accelerate the shift to machine learning ready data collection tools. However, again, the trade-off, this could be very time and labor intensive. Anytime you're bringing a lot of people into a room and trying to come to consensus, that can be a difficult process. So that's a trade-off to consider. Next slide, please. And that's the end of my talk. Of course, questions are welcome. Please type those into the Q&A box so that panelists can be answering those as we go along. And with that, I'll turn it over to Stephen Lin to talk about the National Academy of Medicine report.
Thank you so much, Karen. Next slide. Hello, everyone. So I'm Steve Lin. I'm a family medicine physician at Stanford, a current fellow at the National Academy of Medicine, and one of the co-authors of this NAM Perspectives paper. Our paper was developed as a companion to the GAO's report, which you just heard about from Karen. So for the next few minutes, I'll be outlining the key takeaways of our paper, which really focuses on addressing barriers and facilitating the clinical adoption of AI and medical diagnosis. Next slide, please. Our paper drills down into the key factors related to the successful adoption and acceptance of AI-diagnostic decision support tools, or AI-DDS, in both inpatient and outpatient settings. We organized the issues into 4 domains: reason to use, means to use, method to use, and desire to use. The framework was derived from our understanding of human and system behaviors in response to the introduction of new technologies. Let's explore each of these domains and some of their key action priorities. Next slide, please. First, the reason to use domain explores the alignment of incentives, market forces, and reimbursement policies that drive healthcare investment in AI-DDS. At the outset, the adoption and scalability of a given AI-DDS tool are driven by how well the tool addresses a pressing clinical need. In other words, alignment with providers and health systems' missions. Considering that these tools require substantial financial investment for both deployment and maintenance, the second factor is the tool's affordability, both to the patient and the health system, including the incentives to the provider, patient, and health system to justify the costs of acquiring the tool and the investments needed to implement and sustain it. So one action priority is establishing clinical efficacy and affordability of novel AI-DDS tools. It is important to ensure robust clinical utility as well as cost effectiveness. Establishing the clear impetus to incorporate novel AI-DDS tools into health systems is contingent on a given tool's clinical efficacy, specifically as it relates to a health system's target population, and affordability, both to the health system and the patient. A second action priority is aligning the tools with the health system's missions and target populations. Ultimately, it doesn't matter if a tool is effective and affordable if it doesn't address a real clinical need. You just heard that from Karen's report. A useful framework for evaluating the necessity and utility of AI-DDS tools relates to the quintuple aim of healthcare: better outcomes, better patient experiences, lower costs, better provider experiences, and more equitable care. AI-DDS tools should address at least one, and ideally several, if not all, of these aims. Next slide, please. The means to use domain is about ensuring that clinical environments are properly equipped and have the resources to support and sustain the implementation and use of AI-DDS tools. One action priority is to create a sustainable environment for the adoption and continual use of these tools through capital investment and appropriate reimbursement mechanisms. Investment is needed to obtain and maintain systems that can support a robust AI pipeline, from data processing and curation, to model development and updating, to systems for data storage, archival, and use. In addition, there are also significant human capital requirements. Practices and health systems often lack the required human resources to run a minimum data infrastructure that can support AI-powered applications. Key requirements include frontline IT staff, data architects, and AI machine learning specialists to understand the context of use and tailor the solutions to be fit for their purpose. The infrastructure also requires information security and data privacy officers, legal and industrial contract officers for business and data use agreements, and IT educators to train and retrain providers and staff. Another key consideration is system interoperability. One example is incompatible EHRs within the same health system. Let's say the hospital's inpatient system uses Cerner, but the outpatient clinics use Epic, which cannot speak to one another. So one action priority is to establish consensus-based standards to ensure interoperability, leveraging Smart on Fire APIs, for example. If consensus-based standards do not emerge, then ensuring interoperability could benefit from a top-down regulatory approach. Next slide, please. The method to use domain discusses the workflow considerations and the training requirements to support clinicians in using these tools. One action priority is to increase funding opportunities to advance the implementation science of AI. AI-DDS tools must contend with the considerable heterogeneity of clinical workflows across and within organizations. To navigate these complexities, health systems may need to develop new workflows in a way to reduce the cognitive burden on providers, for example, by delivering just-in-time diagnostic assistance in the most unobtrusive manner to providers, while minimizing clerical tasks that might be generated by their use. These workflows also need to be continuously monitored for performance and adapted. What will ultimately help is increased funding and resources devoted to advancing the nation implementation science of deploying AI-powered interventions that change provider behavior. Another action priority is reviewing emerging AI competencies and integrating these into the current training and certification ecosystem. Health systems looking to use AI-DDS tools must recognize that the introduction of AI can change roles and responsibilities of its workers, and the field needs to be responsive and prepare for these rapid changes. This requires the educational infrastructure to be equally nimble. Training opportunities must be integrated across undergraduate medical education, graduate medical education, and continuing medical education. To the extent that some AI-DDS tools are designed to support collaborative team workflows, interprofessional and multidisciplinary training is also necessary. Competencies surrounding the use of AI-DDS systems are still evolving and yet to be established. Next slide, please. Lastly, the desire to use domain discusses the importance of attending to psychological factors, such as addressing how these tools can facilitate professional fulfillment among providers, including mitigating burnout. The other indispensable element within this domain is trust. One action priority is to promote clinician well-being. Professional societies, trade associations, and healthcare quality organizations should center AI-related efforts to promote clinician well-being through human-centered design in AI technologies, aligned with the work-life balance goals outlined in the quintuple aim. Another action priority addresses the concern that some, but not necessarily all, AI-DDS software is subject to FDA medical device regulation under the Cures Act. It remains difficult for providers to determine whether a given type of AI-DDS tool is or is not likely to have received oversight under FDA's medical device regulations. Uncertainty about these tools likely fuels provider discomfort with using AI-DDS. So the FDA could continue to explore the special considerations affecting design, validation review, market authorization, and post-marketing oversight for AI-DDS tools, offering timely guidance while recognizing that over the long term, notice and comment rulemaking may offer advantages over the continued use of guidance documents. In addition, the FDA, CDC, and ONC could ensure transparency and publicly accessible reporting for flaws and safety incidents related to AI-DDS tools. Next slide, please. Finally, being cognizant of the implications for equity throughout the life cycle of these tools and making a consistent effort to address past, current, and potential future equity issues are critical to preventing widening disparities in healthcare. While there is a lot of excitement to bring AI-DDS tools into clinical practice, poor data quality, prevalent biases in existing healthcare data and practices, and the lack of structural supports available to end users jeopardize progress toward achieving equity and fuel ongoing uncertainties and hesitancies about adopting these tools. In conclusion, the authors believe that focused efforts to create equitable and robust AI-DDS algorithms, streamline integration of new AI-DDS tools into clinical workflows, and train healthcare providers to effectively use such tools, coupled with the strong regulatory oversight and financial incentives, will optimize the likelihood that innovative, clinically impactful AI-DDS systems are adopted and used responsibly by healthcare providers to the ultimate benefit of their patients. Thank you for listening. We hope you enjoy reading the paper, and we'll turn it over to the panel.
Thank you, Stephen. Next slide, please. My name is Matt Hunter. I am a senior analyst with the U.S. Government Accountability Office, and I was the analyst in charge on this project and collaboration with the National Academies. I also worked on the AI and drug development report a few years ago, which I attached a link to in the Q&A just a few moments ago, in case you're interested. I just want to say a quick thank you to all of the folks that we've worked with over the years at the National Academies. It's a little bittersweet to be at the end of this, but it's been really valuable for me personally, and I think for many other folks for the work that it's produced. And I also want to say thank you to everyone at GAO who worked on this, particularly Hayden Huang, Michael Steinberg, Nathan Hanks, and Eric Lee. And in case you didn't see the last chat, it looks like the chat feature should be working now. So just a reminder, if you have any questions or comments, there's a Q&A function and the chat function as well. Next slide. So I'm really excited to introduce these panelists that we have today. As Michael said, they're all leaders and all inspiring in this field. First, we have Connie Lehman. Connie is a Harvard professor of radiology at Harvard Medical School and the founder and co-director of the Breast Imaging Research Center at the Massachusetts General Hospital in Boston. Barbara Evans is a professor of law and the Stephen O'Connell Chair at University of Florida's Levin College of Law. She's also a professor of engineering at University of Florida's Herbert Wertheim College of Engineering. Ade Adamson is a board-certified dermatologist and assistant professor in the Department of Internal Medicine at Dell Medical School and at the University of Texas at Austin. And Dahlia Powers is the Senior Vice President and Chief Information Officer of Data Platforms and Digital Channels across Humana. So we're just going to take the next 20-25 minutes or so and get each of their unique perspectives on these reports and presentations, see kind of how this is applying in their work in the field. And if you have questions during that time, please submit them in the Q&A or chat, and at the end of this portion, I'll be moderating a Q&A discussion to field answers to all of that. Without further ado, Connie, would you like to kick us off?
Yeah, Matthew, thanks so much. And thanks so much to the USGAO and the National Academy of Medicine for the invitation to share some of my thoughts, but also more importantly for the incredibly thoughtful leadership and hard work that the full team members from both groups have brought not only to this event, but to the many years prior. It's benefited all of us in the field of machine learning, AI, and healthcare. So I wanted to expand on some of the themes that were reviewed from the GAO and the National Academy of Medicine so nicely by Karen and Stephen, and particularly from my perspective as a scientist in the domain of AI, but also as a radiologist practicing in the clinic and seeing over the decades how these tools have both had incredible promise and then also how we've learned from some of our failures. And the three themes I'd like to amplify, I think really most importantly is this theme that both Karen and Stephen highlight, which is real world performance, post-market assessment. We really experienced that in mammography with traditional computer-aided detection. In the 1990s, we had FDA approval, people were using it. There was a lot of excitement that, computers don't get tired, radiologists do. Many of us were scratching our heads a little bit because using it in the clinic, we weren't seeing the dramatic impact that we were hearing about from the reader studies. And then when Josh Fenton published showing that this wasn't translating post-market implementation into real world practice, it wasn't translating the same benefits that we had seen in the reader studies. We, with the Breast Cancer Surveillance Consortium, repeated those studies when the technology had had more time to mature and found the same thing. And I think it was a real lesson learned that technology can go so far, but it's the human interaction with the technology that you only are really going to be able to test carefully once you put it out into clinical practice. So there's some lessons learned there, and I'm really grateful how much emphasis is being placed on the importance of that. And I think that one of the things that's been so fantastic about both teams is they've really focused on how we not just talk about it, but how we implement. How do we align incentives? How do we support people to be able to do this? Because all of these great ideas take time, they take investment. And how do we create an ecosystem of an environment where that can happen? I think we have a lot of opportunities and we have some best practices we can leverage on making sure that centers that are bringing AI tools in, depending on the use case, can ensure that they have an ecosystem not only to integrate that in a positive way for their patient population, but also to evaluate it as they move forward and continue to use it in their local environment. So I think those AI-ready healthcare systems really need to have their list of checklists and the incentives to be AI ready so we can continuously assess post-market performance. And I think that, I just really appreciate how Karen gets so focused on this is a policy that we could put into place and we could really align with all the stakeholders on how we can all have that accountability and have that process. The second theme that I think is so critical, and I'm just thrilled to see it have such high importance from both organizations, is the focus on equity. It's interesting for me in the clinic because sometimes I hear people talk about the risks of AI driving more inequity into our healthcare system. But I see it from the other side. The inequities in our healthcare system are so challenging, so disheartening, and we have an opportunity with AI to correct that. I'll give a really basic example. We were evaluating an AI risk assessment tool that had been developed between Mass General and MIT collaborators. And to have a comparison, we use traditional risk models, which are not regulated. They're models where patients would input different factors such as their age at menarche or menopause, how many children they had, how many family members had breast cancer. I was thrilled to see how well the AI risk model performed, but what really opened my eyes more was the inequities in the traditional risk models, something that I think many of us had talked about, had heard about, but when it's actually in your own clinic where you're taking care of patients and making recommendations about supplemental imaging methods to reduce risk based on those scores, that was really eye-opening. So I think while we can think about the risks of AI tools driving inequities, it's actually an opportunity to really address those inequities. Another myth I want to highlight is some people say if you haven't trained models on diverse populations, you can't use it in diverse populations. That wasn't our experience in the lab. What we found, although we had a large database of predominantly about 85% white women. When we tested it in African-American, Asian, Hispanic populations, the performance was quite high. We found the same thing when evaluating or training models, for example, with a Hologic vendor, and then testing on a GE vendor. We didn't need to train necessarily in the same setting that we were intending to use it, but we 100% needed to test it. So I really emphasize that I think it's the testing more than the training. And I'll just close because I could talk for a long time. I'm looking forward to the joint discussion. Both Karen and Stephen so eloquently focused on the importance of culture, and the National Academy of Medicine and the GAO coming together, bringing the FDA and the NIH, incorporating all the stakeholders industry, have really set a model for all of us. And I think it is that multi-stakeholder culture where we remove the silos, we work together, we align incentives. It's really going to help us translate this disruptive technology into transformative care for our patients. So thanks so much, and I look forward to the discussion.
Thank you so much, Connie. The real world perspective and examples really, I think, highlight the lessons and provide a deeper framework for everyone to kind of understand these issues. Barbara, love to hear from you.
Thank you. I also would like to express how impressed I've been by this multidisciplinary effort and how the GAO and National Academy of Medicine brought together people with wildly different perspectives to focus on this problem. I was involved in the paper that is part of this, the discussion paper, that is examining factors on how to bring this wonderful technology into real clinical use. And the desire of physicians and healthcare systems to use this depends very much on the other factors, whether they can see a reason to use it or a means to use it and method. Diagnostic technologies, even the traditional ones that we've had available for 50 or 70 years, have always faced a very challenging reimbursement environment. Healthcare payment systems are focused more and or favor therapeutic procedures and products more than diagnostics. And we saw this when the Medicare prescription drug benefit came into effect about 15 years ago. Congress temporarily suspended increases in diagnostic payments to pay for more drugs. But we are right at a time when advanced diagnostic technologies like genomics and AI decision support systems for diagnostics have the potential to improve outcomes and make our use of treatments better targeted and reduce treatment costs. What we need is a value-based reimbursement framework that is able to grasp what is the benefit, how much is saved, how much is the patient experience improved by a more accurate diagnostic technology. Right now, I agree with the GAO's conclusion that limited data on real-world performance is a major issue that we need to work through. There's sort of a chicken and egg problem. We can't get these technologies into the clinic until it's reimbursed, but we can't get the evidence of clinical effectiveness and utility until it's more widely used in the clinic. So the evidence we have for to support reimbursement, we don't get till it's reimbursed. So this is a real tough nut to crack. And we need to be aware that as we develop these systems and bring them into the clinic, we need some mechanism that's like coverage with evidence development, where we can move them into the clinic in order to study them further to enhance the base of evidence. And I would also caution that we need to be aware that the reimbursement frameworks we have today for healthcare services have not produced equity in the past. And we widely agree that equity is a key consideration that will drive acceptability and desire for this technology. Sometimes it's expedient to try to slot a new technology into the existing payment frameworks that we have. But this needs to work for everybody, and we need some sort of safety net for the uninsured to make sure they have this technology and that also we gather evidence on how well it performs for them. So the real problem is, what does the safety net for AI decision support for diagnosis look like? Is it a data commons, a national infrastructure, public funding such as grants, pilot projects? The shift to AI-enabled healthcare is giving us a chance to rethink equity in healthcare. And rethinking equity may not imply simply replicating the payment processes of the past, which have not achieved equity. We may need to think outside the box on how we're going to finance this. With my remaining time, another major issue that we're all concerned about as patients is the privacy. We all need to wrap our heads around the fact that use of our data in AI diagnostic decision support is a clinical use of data, not necessarily a research use. We all think in terms of the research norms for data use, which are strong consent norms, and each person protects their own privacy by limiting access to their data. That's not the privacy framework we have ever used in clinical data privacy. There, we assume patients are vulnerable, may not be able to get the care they need unless they consent, and law has tended to impose much more stringent duties of confidentiality on the data users, the clinicians, the healthcare systems. This is reflected in state medical privacy law, in laws like the HIPAA privacy rule at the federal level, and even under the EU's GDPR, the member states have a medical privacy law that they define themselves. And this tends to put more duties and restrictions on what can be done with data. And we may need to enhance that framework, because what AI diagnostic decision support is doing is bringing all these new players into the clinical healthcare encounter, such as IT professionals, software developers, who aren't covered by the existing confidentiality norms that state law puts on to clinicians. So we need not just FDA law to evolve, but we need our state laws to evolve, and we need professional societies and accreditation bodies to think through what exactly does this require in order to protect privacy and make it effective in real clinical use. So my conclusion after being involved with this study is that there's an enormous promise here to improve healthcare, perhaps even lower costs, but we have a lot of work to do. This is a major shift that is going to require us to rethink all aspects of privacy, how we protect it, and how we protect it stringently at the federal, state, local level, and through non-governmental means such as professional societies. So thank you. And so my exhortation is we have a lot of work to do. Thank you.
Thank you, Barbara. Chicken and the egg problem is all too real, and I'm interested to get more perspectives on that, especially from Dahlia, from the payer perspective, during the Q&A. Aday, would you like to go next?
Yeah, so a lot of the work that I do is related to equity, not only in AI, but dermatology and medicine in general. And so I'm very excited that the two speakers before me also mentioned equity as something that was a bright spot in these reports. And so I want to echo that and delve a little bit deeper. I know Dr. Lehman mentioned that in her experience, having a diverse data set wasn't necessarily something that precluded the use of a technology in a wider population. I would say that it is a bright spot, but in the field of dermatology, at least, that has not been the case. Training algorithms to recognize certain diseases on different skin types has shown a lot of difference based on how the data is trained. So we have to be very mindful when we think about applying certain algorithms that are trained in non-diverse settings, how they end up, improving or not improving outcomes in the real world. And I think we need to be careful in measuring that effect, as it sounds like they did in this radiology instance. Because the one thing about AI that to me is really amazing, but also presents potential challenges, is the scalability. And if you let an algorithm out there that is systematically biased, then you are at risk of potentially harming a large amount of people. But this is not to say that we should get in the way of the progress in this technology in promoting equity. There's also situations in which this technology could improve equity. I can think of one example related to opioid prescriptions. Perhaps an algorithm can reduce bias related to how physicians decide who should get opioids versus not, which we've seen in many studies disproportionately affects different groups that aren't given opioids for their pain because of the biases related to the decisions that clinicians make. And so I hope that we continue to keep equity at the center of these discussions, because this technology really has the opportunity to not only improve equity, but there's also the danger of exacerbating it as well.
Thank you, Ade. Really appreciate that. Our first question in the Q&A will be geared towards equity. And I'd love to hear your experience as a dermatologist, because we know it faces unique challenges in that space, and that would be really valuable. Dahlia, we would love to hear your perspective from a payer company.
Absolutely. So from a payer perspective, we certainly believe that AI and machine learning is going to be a way of the future for us to improve care, lower cost, as well as have a much better experience for our members, our providers, our internal associates. And it's going to be a huge advancement and a lever that we can all use to improve health outcomes. Humana, probably similar to a lot of other payers, is investing internally in AI and using it to improve outcomes. So some of the examples there were at the beginning of COVID, we applied AI to try to identify some of our members with social determinants of health that were going to be impacted by the pandemic, and we used AI and analytics to reach them to ensure their well-being. So I think from an alignment on the principle perspective, I think we're all probably believers in the power of AI and machine learning to really advance healthcare, and especially in the diagnostic area as well of it. So I think as we look to take the next step as a payer, we obviously have to work with our regulators and CMS as the federal agency that's the nation's largest healthcare payer to be really at the tip of the spear in terms of establishing the structure of how we use the new technology. How do we make sure that all of the different models, AI models, ML models, truly are proven to work as an additional augmentation to a physician in terms of how they can improve health outcomes for the patients. And again, I want to stress that we believe that this is going to be an augmentation or an assistive technology, not a totally autonomous use of AI, at least as a beginning step in terms of adopting it. And again, like everything else that was said before, we need to prove each and every model and its efficacy. and we need the CMS to help us also in deciding on how we can structure the payment models so that we can leverage it more broadly to improve health outcomes for our payers and make also our for our patients, and also make our providers more efficient. We know that some of the AI models can really take a lot of the bureaucracy out of the system, and our providers would rather spend their time actually attending to the patients rather than doing some paperwork or looking at some process that could be highly automated so that they can become more efficient with their time. So I think we're all heading in the right direction. We just need to take very concrete steps to make it happen sooner rather than later.
Thank you so much, Salia. I'd like to invite the panelists back to turn on their videos, as well as Stephen and Karen. If you'd like to participate in the Q&A, feel free to join. So just one last reminder, if you have questions, please submit them to the Q&A, or comments, please submit to the chat. We received a handful before the webinar started that we'll use to kick off the conversation, and we'll try to get to as many of these real-time ones as possible. So the first one we've touched on a bit, but I want to just kind of double tap on it and ask, how can we ensure AI-based tools add value and address unmet medical needs in diverse settings? So a lot to unpack there related to equity, but also diverse clinical settings, smaller versus larger settings, things like that. And this one is open to whoever would like to jump in first.
I can
go ahead.
Make a comment, brief. Sometimes I talk to industry about AI and its use in healthcare, is that there aren't, and this was mentioned in the talk, they do not include physicians in deciding what are the important questions or important areas of need that AI could actually fill. And AI is just a tool, right? And sometimes I feel like it's a tool looking for a problem when it should be the other way around. So I think that clinicians should really be in the center, helping to drive how AI gets implemented in the clinic. And that's the best way that there's going to be success for it to actually be implemented by, Joe clinicians like myself.
I totally agree. I think having those stakeholders engaged from the beginning, and also as the teams working together for these projects have done, is the stakeholders of the patients, the physicians, the full spectrum. I think that that's really key and critical. And does it check the boxes? Does it check the boxes of this is going to improve access, equity, higher value care, improve performance? And if those are the claims, then in the more restricted environments to try to test and evaluate those claims, that would be the first step. But the next one I really believe is, once it's out in clinical practice, how can we have our healthcare systems incentivized to be very nimble to report performance? So whatever the claim was, this is going to improve the sensitivity and specificity of mammographic interpretations. Do we have a system in place where we can measure that after the new AI tool is implemented to see if that's the case, and avoid having 15 years of technology being used, which then someone comes along later and does a big study and says it actually wasn't having the impact we hope for our patients?
Totally agree. And I think about some of those problems in terms of technology, people, and process. And the process part of it, how do we make AI very integrated in the workflow so it can systematically be frictionless, as well as provide us the measurements that we need, and the ability to continue to train some of those models so that they can continue to improve over time And when we start detecting biases or drift, we're able to actually intervene from the technology side and correct that. So I think having that closed loop and thinking about the process, the technology, and the people aspect is going to be really critical for us to advance in the usage of AI in this space.
Really crucial to invoke the right mix of incentives, and there will probably always be a tendency for commercial private sector software developers to favor the medical conditions that tend to be well insured. And those we need to worry less about than the ones that affect people who aren't insured, don't have a line of reimbursement. And that's where there's a role for policymakers and granting agencies and public funding to try to impress a need to address these conditions that may not be covered due to lack of insurance in the population or just limits of insurance coverage. So to go forward and create the incentives, there's going to have to be a mix of market incentives and a role for public funding to achieve that balance.
I agree with everything that's been said, and I really appreciate the question about equity. I feel like in many ways it really goes beyond AI. This is an issue that really is important for all clinical trials of all emerging science and technologies. And to build on what Barbara was saying, the right incentives could help a lot. And beyond that, a mix of both soft and hard governance mechanisms can be used as well. For example, the FDA issued new guidance recently on increasing diversity of patient populations in clinical trials. There are ways, for example, to create governance mechanisms to make sure that funders and also healthcare systems that are sponsoring these studies align their efforts with such guidance and require researchers to meet a minimum bar of geographic diversity and patient recruitment as a condition for participating and supporting their R&D process.
Thank you, Stephen. Our next pre-submitted question was about what is being done to recruit and educate medical students about AI-based tools. Workforce issues are a common theme throughout the three reports that we collaborated on. So if anyone would like to offer some perspective there, that would be helpful.
Well, I would say, of course, we need to insinuate a greater knowledge of these digital technologies into medical training. But I'm not a physician, but what I know about the medical school curriculum is it's pretty packed already. And I think we need to realize we're not going to make every future doctor be an AI specialist. There's such a thing as comparative advantage, where it might be better to have an IT specialist on the team than try to make every doctor be an IT specialist. Part of what we need for that is to create reimbursement mechanisms so that these new professionals that need to be brought in can be paid for, and that they're not just hospital overhead, not a cost center, but realize that the IT specialist, the software developer, will be creating real value and have a real impact on patient outcomes. And we need to rethink the categories of what is the essential team to care for patients in the future.
That's a very critical point, Barbara. When we're working on AI within Humana, we form what we call pods, and they're multidisciplinary, where we actually have clinicians as well as software engineers and data scientists working together to address a problem. And the power of the knowledge that comes from that is what really makes it work.
Thank you.
Yeah, can I just say I in the same way I didn't have classes in how to use an electronic health record. I just went in and did it. I think the same thing is going to happen with AI in medicine. You're going to hear about it. Your attending physicians are going to talk about it, and you're going to see how they use it in real time, and it'll just become kind of part of the discussion. And that's kind of how I see it from a medical student perspective versus an entire class on, AI.
That's really helpful. Thank you. Brian Williams raised a really great point about making sure that we represent the patient perspective, which relates to another question that we got before the webinar about what are the greatest risks to patient safety posed by the use of AI in healthcare. And I would like to sort of combine those ideas and ask for some real world examples of how you're using these in real practice, and how you're making decisions about whether to accept the recommendation from the AI, or how it informs your decision, and how you are working with the patient to maybe educate them on how that was formed, if applicable, or talk about AI more broadly and data more broadly, if at all. Connie or Ade, or Stephen, this would be a great question for you.
Well, we've been really excited. We're still using our AI tools in a clinical research setting at Mass General, and we've been excited to see the different impacts we can have. So, for example, just as one simple example, breast density, it's required that we report that across the country in all of our reports. There's a lot of confusion by patients and providers on exactly how much of an impact breast density should have on the decisions that they make about their care. And there's extreme human variation in assessing density on a mammogram. So our AI tool, we tested and showed that we could dramatically reduce the human variation, not only at our academic center, but also at our community practice sites within the larger Mass General Brigham organization. And the impact on that is significant, both in patients' quality of life, because in what we found was in our community practices, we had a over assignment of dense breast tissue to patients. We had some radiologists that were telling 80% of women that they had dense breast tissue, and that leads to additional imaging and anxiety that is unnecessary and causes more harm than benefits. And so showing that we could so rapidly change that with the AI density that was much more accurate, consistent, had a significant impact on our patient population. The other domain that we worked on was in a 5-year risk predictor, and comparing that to traditional risk models recently published in the Journal of the NCI, showing that when we needed to come back after COVID and try to start to screen again and try to have our higher risk patients come back in first, sort of get to the front of the line, unfortunately, in the first year, as we might all predict, what determined who recovered most quickly was their zip code, their race, and their income. And that is not what we wanted. So by the second year, we had adjusted and changed, including bringing the AI high-risk patients back in, and we mitigated those inequities that we had in year one and brought our patients that were more vulnerable back to their pre-pandemic numbers as well. So we were really trying to leverage the AI tools to tackle our most significant problems, especially around the pandemic.
So I think your question was about safety, right, and potential ways that could be harm. So one area of research that I'm involved a lot in, and Dr. Lehman's probably very aware of this idea of overdiagnosis and the diagnosis of cancers that may or may not have caused harm if left alone. And artificial intelligence has the possibility of actually magnifying that and making that problem even bigger, leading to unnecessary procedures and there's unnecessary labeling of disease and patients that don't actually have it. And that's one of the worries that I actually have about AI, especially if it's not used in a context in which we evaluate meaningful endpoints for patients, which is improvement in quality of life or decrease in mortality. And to me, that is a major issue in cancer. Not only does it relate to clinical imaging, but it also relates to the histopathologic diagnosis of cancer, in which in many tumors, there's no gold standard.
I think beyond the issue of safety, one very important reason to incorporate the patient voice and perspective in all this is accessibility and also the patient experience of the care that's being delivered with the use of these technologies. I like the idea of using patient and family advisory councils, community engaged health equity advisory boards in the design of clinical trials, as well as research and development of health technologies to incorporate the patient voice. We often forget the ones that are on the margins. So patients with disabilities, for example, or patients with limited English proficiency or limited health literacy. It might not be a patient safety concern, but it could be an access issue or a experience of care disparity there as well. So I really like the idea of engaging patients formally in the process at every stage, research and development, implementation, and post-market surveillance as well.
Thank you. All really profound comments. Thank you. We had a question about data sets. Obviously, data is central to AI and to this whole field. And the question was, please discuss what makes data sets at a patient level AI ready and ML ready. And then I'll add a moderator kind of second question to that, which is, what can we do to improve quantity and access to those types of data sets?
So you've probably heard the term data is the new oil. And the implication of that is it's really a source of wealth that we depend on. But also similar to oil, it's not useful until it gets refined. And I think data follows the same pattern. If you get data sets that are actually standardized, the data is cleansed, it's unified, you can correlate it and you can use it effectively to actually enhance the development of AI and machine learning models. So getting access to that data is imperative. And we often actually notice that the quality of data, depending on the source, varies drastically. Sometimes the quality is close to 90%, and sometimes it's closer to 20% accurate or usable. So raising the quality of the data that we use, and that also comes from sometimes from devices, sometimes from EMRs, from EHRs. So all of that actually needs to be improved, and we need to have better standards. I think FHIR is going to improve that as it becomes more widely adopted, but I think we still have room to go until we actually get to a good, a baseline, so that the data sets that we have can be as usable as possible. And of course, in addition to the formatting of it, I think, as we talked about before, the data sets that you use is going to inherently, if it has biases, those are going to impact the models that are built on it. So we have to be very careful about how we take the data sets that are going to improve the outcomes and reduce biases.
Talia, I totally agree with those 2 points you made, and they're co-related, right? Because the very important work to have good quality data, clean data, good images, careful outcomes tracked carefully, electronic medical records tracking of race, ethnicity, comorbidities of the patient. That's very important. And then you can inadvertently be introducing biases because you have such a clean, such a pristine database that doesn't exist anywhere out in the real world. So then you take your AI model that needed that perfect, pristine data, you put it out into the real world and it falls apart. So I think that's why that continuous cycle of both, what is the level of having high quality data? It's very dependent on the use case and the intended use. So there's no one database that's perfect. It's what it is that you're testing, how you're going to use it out in the population once it starts to use. But if we don't finish that cycle and then put it out into the real world to see, a great example, very concrete, was the early enthusiasm about computer vision with the retinal images. But unfortunately, it was such a beautiful, perfect data set that was used to create those AI tools to diagnose diabetic retinopathy that it didn't work in the very populations that they were hoping it would work in, because the image quality out in the real world was not the same that had been carefully selected and curated to develop the model itself.
That's exactly right, Connie. And I think as part of that also, does AI have a role in improving the quality of data and making the images sharper? So that's another also potential application to improve
That immediate feedback, like this image is not acceptable, retake it. Yes, I love that.
Yeah.
I mean, even if you look at the opportunity that was presented with the COVID-19 pandemic and the use of AI, honestly, with as much hype as we had around the technology, it was a spectacular failure in terms of actually being able to adequately predict who was sick, where the next hotspot would be, how we should treat patients, et cetera. I mean, there's many reasons why this was a failure. Data is at the core of a lot of it. Interoperability of EHRs or data that we simply don't have in the EHR that exists or that encompasses patients, what kind of caregivers they have, income, education, all of these things that are really important in predicting what kind of job they have, you know. So the requirement to really be precise might take so much data that we start encroaching on privacy, which is what Barbara had brought up in her talk at the beginning as well.
We have a few questions about liability. And Barbara, I know you have a lot of thoughts on this. Let's see, we have a couple. One was, we've recently seen a proposal to hold physicians liable for harms resulting from the use of clinical algorithms. There's concern if liability trends in this direction, it will seriously impact clinical adoption of these tools. Yet there has been little discussion of how liability should be handled. How do we best address questions of algorithmic liability and accountability, and how will this impact adoption?
I'll be happy to take that one. Being a lawyer, this is something I think a lot about. When I ask people, everybody wants more accountability with AI systems. I've never asked a person who wasn't for accountability, but nobody's for liability. And that's kind of a paradox, because the liability system is one of the major ways that the US legal system assigns accountability. If you, through your decision or action, contributed to a harm, the tort system exists to make you contribute to compensation. So we need to kind of deal with liability, but do it in a way that will allocate the burden of liability fairly. All too often, up till now, and certainly in the past, the physician or other clinician, but mostly the physician, is the one who ends up holding the liability bag, because they're well insured, they're a deep pocket for liability, and we have very well established pathways and causes of action for medical malpractice. In the world of AI-enabled healthcare, we have multiple contributors to decisions, such as a diagnostic decision. There will be the role of the clinician, but there's also the role of the software developer. And in the past, software developers escaped liability because they said, well, we're selling a service, not a product, so you can't hold us liable for product liability. But when FDA entered into regulating medical software, certain types of it, that makes it a product as far as the product liability system is concerned. So I think the future, and this is all evolving and we don't have much case law to rely on, there will be a division where some things are assigned that the physician is responsible for compensation, and some things the software developer may have liability. And that might actually make physicians be a little more comfortable using this if they weren't holding the entire liability burden. For example, if a software developer trains its software on a very narrow, unrepresentative population of, say, rich white males, and then rolls that product out for general use, that's a design defect. There's a product liability action that can be brought for that. If a product has a bias that isn't disclosed, there's an action in product liability for failure to warn. So I think I realize how most people think liability is really awful and bad, but this is a major accountability mechanism. And as long as we can get to some liability rules that provide a fair allocation of who's responsible, it could be something that helps move this technology forward.
Thank you. A quick follow-up on that. So other medical devices, is there a product or a service under law?
They're a product. If FDA regulates it, it is defined by law to be a medical product at the federal level, and tort law exists at the state level, and they defer to the federal definition. So FDA regulated medical software, I feel fairly convinced, will be subject to product liability. However, it matters how FDA regulates it. If FDA approves these things through its pre-market approval process, state suits are then preempted and can't be brought. But if it comes to market through 510K or de novo, that the FDA clearance for market can exist alongside state lawsuits. It's evolving. I think we'll have a better picture of it as these things move into the clinic and cases are brought. Right now, there's a dearth of case law, so it's all sort of speculative.
Yeah, thank you. On the subject of evolving, we have a question about adaptive algorithms. The question is from Patrick Ross. He asked, the current regulatory framework from FDA focuses on locked AI systems. The full promise of AI likely won't be realized until these tools move to continuously learning models. How do oversight and patient safeguards need to change to enable this shift? And one thing I'd like to add to that is FDA released final guidance just a week ago related to this and some other areas. So if you're interested in that subject and haven't seen that yet, I can find the guidance and share it via chat. But this question is open to anybody who's interested.
I think it's a fantastic question, and I really think it brings us back to how do we continue after post-market implementation, how do we continue to assess? And we can't monitor what we're not measuring. So if we're not set up to measure the performance of new AI technology we've brought into our healthcare systems, we're not going to know. And it's not just in order to support continuous learning and continuous evolution of the models. It's also, even if you have a locked model, other things change. For example, if there's a model to interpret retinal images or mammograms or chest CTs, the technology of all that is changing. So even if your AI model is locked, your patient population may be changing, the disease is changing, the technology is changing. So we want to be able to continuously monitor and do it in an efficient and a thoughtful way. And also that sets us up in a fantastic position to be able to leverage the power of continuous learning in AI. And we don't want to have to lock our models because it's just too arduous to continue to improve them and go back to the FDA every month to say, we changed it a little bit, we made it better. So I think there's a whole domain there, but it's going to come down to post-market, it being able to be nimble in monitoring and measuring performance of these tools in the specific use case domain.
Thank you. There have been a couple other questions related to, or somewhat related to, autonomous diagnostic systems, and been monitoring the chat a little bit, and there's been a discussion about how the tools are actually used and whether or not they're making a diagnosis or informing a diagnosis, and what happens when the clinician disagrees with the diagnosis, things like that. I'm curious if there are any comments from the panelists on that subject.
I've run into this before. I have an AI-powered mole decision, tool that has gone against my clinical intuition, and I was correct, and the tool was not correct. But then we can get an argument like, for early cancer, is it really true or not? Anyway, that's another discussion. But and I also have asked patients anecdotally their opinion. If there's a difference of opinion, what should I do? And I get a different array of answers, but usually it's, doc, I support whatever you think, and so I think this speaks to there always having to be a role of the clinician for a diagnostic purposes, at least, I think, which is really important that they're involved in that process.
I totally agree. And, in radiology, this was the big fear factor early on when Jeff Hinton had his very famous talk in Canada saying radiologists are like Wile E. Coyote. They've run off the cliff and they don't even realize it yet. We should stop training radiologists. And you could imagine that was heard in a lot of radiology communities. We know that radiologist jobs are going to shift and change for the better. We're going to be able to do more of those things that really leverage our human strengths. And we're going to be able to have computers take over the very tedious, the types of tasks that computers do better. Even when we have like autonomous tasks that we all know we use red blood cell counts, white blood cell counts, we still have a doctor that's talking with the patient about the results and what to do with that. So I think autonomous is an unfortunate label that has made people have this knee-jerk reaction of we're not doing autonomous. And there's domains where you could do autonomous. In screening mammography, we have radiologists trying to pull out 10% of exams that need more attention. I can't imagine there's not a roadmap that a computer is going to be able to do that well. We have a lot of research to do. We have a lot of testing to do, but I cannot imagine we can't move to that domain. Right now, we have wide human variation with recall rates as low as 3% and as high as 30%. That is unacceptable. If we can have tools that can get, in a more reasonable, consistent recall, and then have those smart radiologists going through those recall exams, we can get there. We have a lot of work to do, but I think we can get there. And again, status quo is we've got wide variation. So when people say I wouldn't be comfortable, some of our younger patients say, I'm not sure I'm comfortable anymore having a human read my mammogram. I'd rather trust a computer. So we're evolving, and we'll just make sure we're doing very careful science as we go.
Yeah, absolutely. I think that's a really important point. I think there's a common fear that the AI, robots will replace your doctor, but the hope is that they can augment in a way that makes the human qualities and connection, even more pronounced and important.
Yeah, and most AI models are capable of giving you a confidence score as well. So where they think it's a highly confident result versus this really needs a human to take a look at it and make a decision. In other industries as well, that has been proven as the case. Now, obviously, healthcare is a much more sensitive area, so we want the accuracy and confidence to be much higher than in other industries. But that's where it's probably going to take a while until we get to that 100% trust.
Thank you.
And we may never get there.
Yeah. We only have 2 minutes left, so there is one last question, maybe directed to Stephen. If you can answer it super quickly, that would be wonderful. But if you think it's too long of a question, that's okay. This is from John Birch. He said, please distinguish AI tools in ambulatory primary care settings from those in acute care settings.
I think those tools that are in acute care settings and also to a certain extent specialty settings, a lot of these AI tools are focused on diagnostics and really applied at the individual patient physician level. Where I think tools for primary care and population health are a little bit different is that they are not applied necessarily always at the individual level, but also at the community and population level. So think about tools that allow us to manage entire cohorts of patients and identify risk factors for preventable utilization or risk factors for clinical deterioration, for example. but also tools that are not necessarily just focused on diagnostics, but also at the quality and care delivery aspects of things as well. So there's just not enough time to take a deep dive into that. But I do think that there are very real differences between the use cases in primary care and population health versus more acute care settings, inpatient settings, and specialty care settings that deserve a lot of attention from both a research and development perspective, but also a policy and funding perspective as well.
Wonderful. Thank you, Stephen, and thank you to all the panelists and audience members for the questions that aided in such a rich discussion. Michael, would you like to close us out?
Well, thank you very much. It's been a remarkably rich discussion, and on several dimensions. Obviously, we've had a glimpse of the opportunities for the application of artificial intelligence to diagnosis, as well as a very informative sense of what it will take to enhance appropriate uptake of the tool. But really, the discussion has been even more than that. It's been a discussion that has informed us and underscored for us the broader issues of health system performance, both the performance characteristics and the improvement characteristics in many ways, which I take as encouraging as an indication of the extent to which AI and its success will be uplifting across the board to health system performance. By that, I mean, if you look at the characteristics that Stephen identified with from the paper that the NAM colleagues did, the 8 characteristics: incentives, infrastructure, resources, workflow, efficiency, fulfillment, trust, alignment, incentives. If you add in transparency and continuous learning, those are the characteristics of a high-performing health system generally, not just to the uptake of artificial intelligence. And if you look at the factors that have been raised by all of you that are important for improvement of the application of AI in diagnosis: patient engagement, real-world learning, cross-disciplinary leadership, data set integrity, as Dahlia said, data is the new oil, or data as a core public utility, bias-free decision-making. All those are fundamental features of a high-performing health system. So I think the stage is set for progress, the appreciation of the extent to which the power and the promise of artificial intelligence and the factors involved in enhancing its application will enhance the overall performance of the health system, not just around AI, but across the board. So thanks to all of you who have joined today, obviously. Special thanks to the authors and panelists of the papers, and those who reflected on it. And of course, I have to end where we began, and that is on behalf of both all of our colleagues at the NAM and at the GAO. Thank you for this partnership. We look forward to the very productive results from it for quite a while. We look forward to more to come. To be continued then in that respect. Take care.